She gives history of dysphagia, initially for liquids which has slowly progressed to solid food intake. She gives history of pain in the right shoulder region, which is mild to moderate in intensity, present throughout the day, not following any trauma. It is relieved by analgesic, partly about 10 to 20%. There is no restriction of movements at the shoulder or abnormal movements or sensation in the upper limb. She does not give history of dyspnea, cough, hemoptysis. She gives history of loss of weight, about 10 kgs in last 2 months, which is significant. She does not give history of headache or syncopal attacks. There is no symptom suggestive of hypo or hyperparathyroidism. Sorry, hypo or hyperthyroidism. I'll continue with the past history.
Yeah, you continue. Entire history will discuss.
Okay. She's a known hypertensive on oral medication tablet amlodipine 5 mg. She's not there is no other medical comorbidities. No history of major surgeries in the past. She's underwent tubal ligation 25 years back. No, there is no history of exposure to radiation. No significant family history suggestive of clusters of thyroid, colon, upper GI, or any other malignancies in the family. Personal history, she's addiction history. She's a known tobacco chewer since last 12 years, which she's quit since 10 years. Reason unknown. There's no history of alcohol intake. She's mixed diet, bowel bladder are regular and normal. She has disturbed sleep since 2 months. Menstrual history, she's postmenopausal since last 15 years. Treatment history for right shoulder pain. She's visited multiple physicians for which she was taking analgesic and has undergone evaluation with MRI of spine. She's also come with a PET scan done at the same time to our hospital. There's no history of needle test being done in the past.
So just summarize.
So, elderly lady, 60-year-old, postmenopausal, with a long-standing history of swelling in the anterior neck, which is slowly progressed to the present side with no recent change in size or pain. She associated with dysphagia, which is progressive, no no airway compromise, complaints of right shoulder pain, which is non-traumatic, which is there throughout the day, even at rest, relieved with analgesic. She does not give history of dyspnea, cough, or hemoptysis. There is no symptoms suggestive of hypo or hyperparathyroidism. Family history is non-contributory. She is a hypertensive on medication with no other comorbidities, surgeries, or history of exposure to radiation.
You need to tell it in single go. Okay, whatever you are summarizing, no, it should cover the important salient points, but in a single go.
Okay.
So, okay, fine. Coming to your demographic history. So, what is importance of where they are? First of all, what is importance of sex in thyroid malignancies? What is difference between presentation in a male and female?
By presentation, it is more common in females compared to males, but by risk of malignancy or prognostically, males, the chance of malignancy is more in males, and it is a risk factor when we consider male as by gender.
So they're more aggressive tumors.
Aggressive.
Okay. So females, though the incidence of thyroid swellings is more, okay, the incidence of malignancy is comparatively less aggressive than males. Okay.
Okay.
So what does the age tell you?
Age is included in the staging system as well as prognosis with cutoff of 55 years. So while prognosticating, we use age as one of the important factor. And depending on, there is a predilection for certain malignancy depending on the age. Like earlier, like 30 to 40, mostly papillary, followed by follicular, which is around 50 to 60, and later like 60 to 80, anaplastic present by predilection to age. And younger, less than 18 years, and elderly, more than 55 years, have an increased risk of malignancy.
So basically, it is for staging and prognostication. Okay, and by the most common decade of presentation, you might get a clue to what type of malignancy it might be. Okay, first, then what is the area from which they are hailing will tell you any importance?
Iodine depleted areas, hilly region, where goitrogenic conditions where they can present with long-standing multinodular goiter.
Okay, what is that most in India? Where is that risk more?
Himalayan
Which is the goitrogenic belt? It's more of a gangetic belt. Gangetic belt. Okay. So, what is more common there? Is it malignancy or it is goiter? Multinodular goiter.
Long-standing multinodular goiter.
Okay, long-standing multinodular goiter or iodine deficient can lead to what kind of malignancy?
Follicular, long-standing multinodular.
Yeah. Yeah. Then tell me something that she has presented with long-standing swelling in front of the neck, right?
Yes.
So what all at this, leaving your history apart, so what can all be the differential diagnosis for a midline swellings in the neck or a lateral swellings in the neck?
Okay, midline, since it is long time, we can categorize midline swellings as congenital, inflammatory, or malignant. By origin, they can be from the thyroid, lymph nodes, or laryngoceles. Lateral neck swellings, whether they're upper or lower, will tell us whether they're, again, they can be classified as inflammatory or malignant. It can be lymph nodes, probably metastatic in lateral swelling.
Okay. If you can give a few examples of few midline swellings and few examples of lateral swellings.
Okay, midline swellings, thyroglossal cysts, laryngoceles, thyroid, it can be benign or malignant. It can be just adenomas, multinodular goiter, thyroiditis, or differentiated malignancies.
So basically thyroid. Next, you told?
Huh?
Next is thyroid is one.
Thyroid.
Yeah, tell.
Suboid bursitis.
Okay. Then Sana, you told one more thing. Tell.
Laryngocele, thyroglossal
Thyroglossal cyst. Yes. Then
Lymph node.
yeah, submental lymph node is more little lateralized. Okay. Submental, correct. Submental lymph node.
Delphi and clearance.
Sorry.
Suboid bursitis.
Yeah. Subhyoid bursitis, thyroglossal cyst, thyroid swelling, submental lymph node. Anything else?
Larynx. Larynx angina. Ludwig's
Ludwig's angina. Little. Okay. It should be
Delphian node.
granula.
Plunging granula.
Plunging
Delphian
granula.
node.
Okay. Okay. Can it be any mediastinal mass which is protruding into the neck?
Thymoma.
Any superior mediastinal tumors can present. Okay. Can plunge into the
In that
localized
case,
swellings.
पर मैडम मीडियास्टिनल मास प्रोट्रूडिंग में लोअर बॉर्डर पाल्पेबल रहेगा ना, नहीं रहेगा ना मतलब?
No, I'm not asking where lower border is palpable. I'm asking centralized swelling versus lateral.
अच्छा सेंटर.
Okay. Yeah, lateral swellings.
Lymph nodes can be a different length.
Okay.
Parathyroid adenoma.
Okay. Though it's not very frequently palpable. You have some muscle there, no? Can it be some that muscle tumor?
Soft tissue mass of SCM.
Bronchial cyst and fistula.
Bronchial cyst can
Cystic
present.
hygroma.
Sternobascular tumors can present. Okay. Lymph node can present. Even thyroid swellings can lateral.
Yes, all lateral.
But they can present as occult lymph nodes in PTC. Okay, these are about differential. So, can any history of trauma did you means? Is it important?
The cause of swelling, if it is recent onset change. Yeah,
Yeah, it can be still a hematoma, no? So that swelling can be still a hematoma. Okay. So now your patient has swelling in the neck, which is of long duration, with any onset. It is recent onset dull aching pain. So what is the cause of pain in the thyroid swellings?
The recent onset of pain is rapid increase in size, hematomas, malignant transformation with infiltration to surroundings.
So hematoma.
Thyroiditis.
Thyroiditis, correct?
Thyroiditis and
Hemorrhage within the capsule can cause stretching of the capsule, thereby causing the pain. Okay. Anything else? Advanced malignancies. Okay. So these all are the reasons for pain in a thyroid swelling. Okay. So now, what is the cause of? What all will you tell me? 4 symptoms which you will ask in a case of swelling in front of neck.
We'll ask the onset, duration, progression, local symptoms with respect to airway, dysphagia, airway in terms of breathing and voice change. Then we'll ask about symptoms of Horner's symptom for cervical sympathetic plexus involvement.
So why does the thyroid swelling? We discussed about pain. Okay. Then why does the thyroid swelling cause difficulty in swallowing?
One, by the size itself being large. Second, infiltration.
Infiltration of what?
Into the tracheoesophageal groove, and it's causing compression externally with infiltration, or by itself by the mass.
So more so often it is the compressive symptom due to the huge size of the swelling. Okay, very unlikely that it might be causing infiltration to the esophagus. Okay. So anything else which might cause cough or in a thyroid swelling?
RLN involvement, if there is cord abnormality, there can be aspiration and cough. That's one.
And what is the reason for hoarseness of voice?
One, by the per se of the gland enlargement, or by the nodes which are compressing the RLN, or infiltration causing change in voice.
One is nerve involvement, you are telling. Okay. So that is extrathyroidal extension causing nerve involvement. Anything else?
If it is tracheal infiltration, there'll be noisy.
No, hoarseness of voice. I'm asking about hoarseness of voice. So, which swellings in thyroid will cause hoarseness of voice? With respect to location, I'm asking.
Postromedial posterior location.
Yeah, posterior location, multicentric disease with extrathyroidal extension, or due to per se any lymph nodal metastasis. Okay. So then these might lead to hoarseness of voice. Okay. So we also already discussed about aspiration. Now, okay. So what are the symptoms of hyper and hypothyroidism? Start from head to toe.
Okay. Hypothyroidism, loss of hair, weight gain, cold intolerance, constipation. In menstrual, it will be amenorrhea period.
Okay, let me help you. Loss of hair, you told. Anything related to eyebrows?
Lateral eyebrow loss is also there.
Okay, then anything related. Okay, anything related to forehead? There is one sign, no?
In hyper, there is that jelly neck, loss of forehead, wrinkling.
Yes, hyper. Correct. Correct. Hyper.
Eye signs in hyper, where there'll be steady look, lack of blinking, rectus abnormal, like Mobius sign.
Okay, I will ask you. You tell me what are the signs. Okay. So, what is Stelvog sign?
A steady look, lack of blinking. I'm not sure.
No, Stelvog is what? Anyone else? Staring look is correct, but
Staring look.
Lack of blinking.
No blinking.
Yeah, why does that happen? Sorry?
Yes, vector palpebral involvement.
Yeah. So, whether it will be medial or what is the sign? What is Jeffrey's sign?
Forehead wrinkles are lost.
Yes.
Forehead wrinkles are lost.
Yeah. What is Knapp-Seeger's sign?
Medial convergence, lack of medial convergence.
No. Knapp-Seeger's sign? What is lack of medial convergence sign?
Mobius.
Mobius sign.
Mobius.
What is Knapp-Seeger's?
When we can see the sclera from above.
Yeah, when we stand behind back of the baby, we can see the sclera. Next, Jelinek sign. Hello. You told already. Some pigmentation you told. What did you tell?
Upper eyelid pigmentation.
Upper eyelid or hello?
Upper eyelid.
Are you able to hear me?
Yeah.
Yeah. Tell ma.
Pigmentation.
It's periorbital hyperpigmentation.
Okay.
So, that is also seen. And then what is the Berry's sign?
Berry.
Yes. Not eye. I'm just asking.
Thyroid.
Thyroid. What is Berry?
Berry's sign is infiltration of the carotid, which leads to impalpable pulsation of the carotid. It is positive and you cannot feel or the pulsation of the carotid.
So there is something Berry's 1 and 2, no? What is Berry's 1? What is Berry's 2?
Don't know.
Is it just pushing of the capsule or is it just infiltration? So loss of carotid pulsation in the original position is Berry's 2. Okay, displacement of the carotid pulsation, but they're present. Okay, that is where it's one. Okay, one is due to displacing of the carotid sheath, one is due to infiltration. Okay,
So one is displacement, two is infiltration.
one, if I'm not wrong, one is lost and two is displaced. It is other way around. Okay? Yeah. So, and what is okay? Few things about examinations. Okay. So, how do you? What is method of palpation of thyroid?
Now, it depends on the neck of the patient, whether it is short, stout, wide, and whether it is a small thyroid swelling that you are palpating for more nodules or not. So, neck extension by Pisselow's method will help us examine in short neck patients, making the thyroid more obvious. In Kreil's method, by using your thumb, you can palpate for more nodules on the thyroid lobe on deglutition. By Lahey's method, you can make the lateral lobe more prominent by pushing it on the other side to palpate the thyroid.
Okay. So, Lahey's method is from the side to palpate the other side. Pisselow's is the short neck. Okay. What is Kreil?
Kreil is thumb used to palpate whole of the lateral the lobe for more palpation of more smaller nodules.
It's for small swellings. Okay.
Small.
Yeah. So, why does thyroid move with deglutition, Sana?
It's because of the condensation of the pretracheal fascia. It is attached to the trachea through Berry's ligament, which is a condensation of the pretracheal fascia and the posteromedial aspect. So the
where does it get
tracheal
attached?
framework moves. So along with that, the thyroid also moves.
Okay, so where does this fascia get attached?
The posteromedial side, near the Berry's ligament. To cricoid.
It encloses the thyroid gland, and where does it get attached?
Above to the hyoid, inferior to the cricoid, medial to the larynx and the trachea.
Okay, what is the other swelling which moves with the deglutition as well as protrusion of the
Thyroglossal.
Okay, where does the thyroglossal cyst, why does it move with protrusion of the tongue?
Its origin is from the foramen cecum, which is related to the base of the tongue. So it descends in the anterior region of the neck, which moves along with the tongue movements also.
Okay, fine. Okay, we'll discuss the rest of the examination points later. Now you tell me, so you have some swelling which is causing recent onset of compressive symptoms. Okay. And by the way, you didn't tell me 5 points. You tell me about hypo and hyperthyroidism, 5 symptoms.
Weight gain, which is unintentional weight gain or weight loss, cold or heat intolerance, anxiety, tremors, alopecia, bowel complaints like constipation or diarrhea, menstrual irregularity, it can be menorrhagia or oligomenorrhea, with excessive sweating, palpitation, and hyperthyroidism.
Okay. Which causes more brunt on central nervous system and which causes more brunt on cardiovascular system?
Hyper is on central nervous system, hyper is on cardio.
So can you tell me the reason for this? No. Hypo on cardiovascular system, hyper on central nervous. Okay. So
Primary and secondary is there.
yeah, primary is mainly primary hyperthyroidism is central nervous system. Okay, secondary it is more cardio, but hypo affects more of cardio rather than neuro. Okay? So MIs are more common in hypothyroid patients. Okay, so yeah. So why do these eye signs occur, Sahna, in hyperthyroidism and all? What is the cause of exophthalmos?
It is the deposition of the glycoproteins in the retroorbital region.
Glycoprotein?
Mucopolysaccharides.
Lipopolysaccharides in more commonly like behind the eyeball. causing protrusion of the eyeball forwards. Okay. So what about so any other positive symptoms? Can you just go back? If we have to tell me relation of you have asked about radiation exposure. So why did you ask that?
Long-standing radiation exposure is a risk factor for malignant thyroid swelling.
Long-standing? Any specific radiation that was implicated in exopathogenesis?
Mantle radiation
Mantle field, old mantle field, which includes.
So where was this mantle radiation used? Or okay, is it low dose radiation or high dose radiation?
Low dose.
Sana?
Low dose. High dose, ma'am.
Long time is actually the incident in Japan that led to radiation exposure environmentally. Chernobyl was one of the thing, but mantle is high dose for a short duration.
No. Mantle is low dose radiation, okay, which was implicated. It was not only like mantle. They used to use this for acne, okay, adenoids and all those. So that was low dose radiation. Always remember, it's not high dose radiation that causes malignancy. Okay, it's always low dose radiation for a long time. Okay, so the scattered radiation has caused sublethal damage. Okay, whatever was happening in Chernobyl accident and all, so that was scattered radiation. Okay, so more than 30 gray exposure will cause lethal damage to the cells of thyroid. So it causes more of hypothyroidism, not the malignant change. Okay. So less than 30 gray will cause sublethal damage, which brings about changes in DNA breaks. Okay. So this over 20 years and all, they will accumulate all the changes, leading to the pre-malignant state and then finally malignancy. Okay, it's always low dose radiation. Remember. Okay. So so you told about elderly and young. Okay. So anything like those who were exposed to this Chernobyl accident, no, there were endemic sublethal damages. Okay, that led to. Can you tell me the duration between suppose follicular you take? Okay, so follicular and then the change to malignancy. What will be the average duration?
15 to 25 years for.
Yeah, it will be more than 20 to 30 years. Okay. So for radiation to cause malignancy, how long will it take?
10 years.
Minimum 5 years, maximum 40 years.
10 to 15.
Yeah, 5 to 20 years. Minimum of 5 years.
5 years
But maximum majority of the changes will be over 20 years. Okay. So now what happened in this Chernobyl was that there was nuclear fallout and people were not evacuated from there. So they were repeatedly exposed to this low dose radiation. Okay, repeated re-exposure, and finally over over a period, then they developed this DNA changes, and finally they got the malignancies. Okay, so where did this happen?
Russia.
Not Russia, yeah.
Japan or like.
बाहर बहुत शोर है.
Ma'am, Chernobyl is in Russia, na ma'am. The Hiroshima and Nagasaki. Yeah, Hiroshima and Nagasaki, Japan.
Yeah. So what was this Chernobyl specific area is a Belarus. Okay, they were exposed. Okay, so in Japan and France, that's pursued due to the nuclear explosion. They had got this. More of like those who were pregnant and children, they had more of this changes. Okay, so yeah, so then what they used to give this potassium iodide tablet. Okay, so for absorption of the radiation. Yeah. Any drugs you did you? It's me only. But any history of drug exposure? Can you tell me few goitrogenic agents?
Isoniazide.
Solarbutasol.
Lithium.
Amiodarone.
Lithium, amiodarone, para-aminosalicylate.
Phenylbutazone.
Pass. Para-aminosalicylate. Okay, these are few goitrogenic. Any diet which are goitrogenic?
Cabbage.
Cassava,
Brassica family.
Brassica.
Yeah, Brassicaceae family, like turnip, cabbage, kale. Okay, these are all things. Okay,
Sea
so
fish.
yeah,
Sea fish is also, ma'am.
yeah, that is ideal. Okay, fine. Tell me, what are the hereditary syndromes associated with each of the thyroid cancers? Like, what is the hereditary syndrome associated with PTC, MTC, FTC, anaplastic, and genes?
Okay. Cowden, Fab,
PTC.
these associated with papillary.
Okay,
And
I'll give you the
follicular
genes. You tell me. Okay, PPAR gamma.
PPR
Which
Carney.
Follicular.
PPAR gamma,
Carney's complex
P10.
with papillary and follicular both.
Yeah, more commonly papillary. What is RAS genes associated with?
Follicular differentiation. So follicular.
Yeah, RAS. What is BRAF associated with?
Papillary.
Okay. What is anaplastic gene?
Third mutation, but
P53.
353, ma'am. P53.
Yeah, P53. Dedifferentiated most cyclin dependent kinases and P53. Then medullary.
Red proto-oncogene.
medullary
Red proto-oncogene. Yes, red proto-oncogene. Then
रेडिएशन एसोसिएटेड पीटीसी के अंदर भी रेट आता है ना?
yeah.
हाँ.
It will come. But more commonly medullary. Okay. And what about that's more common. Okay, fine. So any difference between suppose it's adenoma. What is a solitary thyroid nodule?
27 तारीख को 26 को तो
defined as nodule in the milieu of normal thyroid gland, which is confirmed by radiology.
17
Any refined definition?
It's a single nodule. It is palpable with normal surrounding thyroid parenchyma, clinically plus radiologically confirmed.
Clinico-radiologically distinct. Okay. So suppose it is adenomas. Okay. So what adenomas are common in young or old age?
Younger ages.
Yeah, they are common in males or females?
Females.
And malignancies are common in?
Extremes of age and males.
Males, correct. So, do you know about was there any screening studies which have published that there is increasing incidence of thyroid malignancy? Do you know any study?
No, I'm only
They
for
told
GH.
follicular thyroid cancer is static, but papillary thyroid cancer is increasing. They have done screening for thyroid cancers.
Because of increase in incidentallomas, because of investigations, usage of PET and imaging, that is what.
Yeah, these were some Korean studies, okay, which have picked up less than 2 centimeters nodules, okay, and they grow very slowly, okay. Suppose in 100%, Sana, how many will be solitary thyroid nodules?
In say about 30% of them.
So amongst all thyroid swellings, they'll be present. 50% will present as solitary thyroid nodules, and only some 12% will be on palpation. You can feel them. Okay. So most of them will be picked up. Half of them will be picked up by sonography only. Okay. So that's how that study had created a lot of disturbance. Like when they have picked up so many thyroid swellings, they didn't know what to do. Okay. So yeah. So whatever you feel like malignant, among these only 15% might be malignant, and you should refer them to higher center. Okay.
Okay.
So,
what? Okay. So can you tell me anything else in etiology we have left? Okay, what is thyroiditis? Etiology of thyroiditis. How many types of thyroiditis are there?
Acute, chronic granulomatous. Read is I can just name. I don't know the classification. It can be acute granulomatous thyroiditis, Riedel's viral thyroiditis,
which mimics malignancy.
Riedel's thyroiditis.
Okay, and which is caused post-viral etiology. So they're picked up more as painful swellings. What is that thyroiditis?
Dequirent thyroiditis.
Yes, dequirent more picked up. So what causes? What has implication in causing a lymphomas? Which thyroid? Okay. So any other very rarely, though it's more common to cause lymphoma, it can cause which type of malignancy other than lymphoma?
Papillary.
Yeah, it can cause papillary also. Okay. So then okay, fine. Then etiology we covered. Past history. What are you interested in knowing in past history?
इसको थोड़ा खाली करो, बंद हो जाएगा ये.
Past history, we would want to know thyroid supplementation, any surgeries to neck, then past history of
you should know any radiation exposure, any goitrogenic drugs they're taking. Okay.
yeah.
And personal. Any specific thing you would like to ask in personal in a thyroid case?
चार्जर मेरा नहीं है पापा.
Diet. Whether the patient is taking iodine diet or not. Iodine diet. Whether the patient is taking iodine.
Does thyroid have any issues with sleep?
Disturb sleep and hyper.
Yeah. Does thyroid have any issues with bowel bladder disturbances?
Yes.
Loss of weight and loss of appetite?
Yes, ma'am. Yeah.
So everything in personal history is important, as well as if it's a female. So any loss of pregnancies, any amenorrhea, menorrhagia, menstrual cycle is very important. Okay. So other than that, family history we have covered. Tell me syndromes with thyroid malignancies.
Cowden, Fab, Carney's, Gardner's, McCune Albright. This is for differentiated. Medullary men syndrome associated, men 1, men 2, and familial medullary.
Okay. Any follicular associated thyroid cancers?
Cowden and Cowden.
Cowden.
What about Fab?
And
PTC is not.
So Gardner syndrome?
PTC.
Follicular man.
Follicular. Okay. Yeah. So these are the few syndromes which are associated with thyroid cancers. So yeah. Shall we proceed to examination? Anything else you want to ask?
So
he has pain in the right shoulder and back. So at the end of your diagnosis, what do you think is your You want to give differential
हो गया
diagnosis?
पापा, अब वो
What is
उसमें
your
खाली रहेगा
provisional
तो वो
diagnosis?
टूट जाएगा। खाली
By
नहीं
the
तो टूट
location
जाएगा।
and the presentation looks like
दबेगा
probably
ना
a
वो समझ हाँ, उधर
malignant,
से
sorry, a thyroid swelling with local symptoms and probable distant
इतना ही रखो,
metastasis
दोनों
also.
साइड बराबर रखो, इसको एक साइड
Can't
खत्म
think
हो
of a congenital is ruled out. Lymph nodes unlikely. Probably a swelling of thyroid origin with local end.
Okay. Can it be some metastatic?
But after retrospectively seeing from the examination, the location and the classical appearance could not.
So
I could not think of.
Etiologically, you think it is arising from thyroid,
Yes.
right?
ठीक है बस
Yes.
बस
Pathologically, you think it is malignant.
Probably malignant, yeah.
Why malignant, Sana?
ये inner radius
One long-standing, which has caused recent onset of local symptoms, as well as the bony symptoms, which is probably metastasis. So,
Okay.
and it is painless also. No
अब इस
fever,
बैग की
no
क्या जरूरत है? दो
association
ट्रॉली
with.
लेके जा रहे हैं।
Okay, what are the signs of malignancy in an otherwise normal thyroid gland? What do you suspect?
Any signs of
Give me
local
4 signs, so 4 symptoms
मैं चलाऊंगी उनको चल
by which will rapid increase in size.
increase in size, change in voice or noisy breathing, dysphagia, which is local compressive symptoms, and mostly
These
no
all can occur in these can occur in a huge goiter also, no? You are telling compressive symptoms. I'm asking malignancy.
infiltrated
Rapid
RLS.
Rapid is increase in size, pain, hard nodule, presence of lymph nodes.
In history,
Recurrent laryngeal nerve injury, hoarseness and
Recent onset.
with exam-
Recent onset increase in size. Church. Recent onset of new symptoms.
So recent increase in size with pain. Okay. So any other thing? Hoarseness. So otherwise, the other symptoms can as well be present in a huge multinodular goiter compressing the adjacent thing. Okay. So difficulty in swallowing can be present. Okay. So all this can be present if it is a huge goiter swelling also. Okay. So yeah, go ahead.
History suggestive of distant metastasis.
History of bone pains here. So where does okay now one more thing, one more question here is like this. What is the more common site of metastasis to PTC? What is the more common site to FTC? What is anaplastic and what is it to medullary?
Okay, papillary and medullary will cause more of lymph node metastasis, whereas follicular is hematogenous more to the lung and bones, where anaplastic is local symptoms with distant metastasis to lung and other sites it can be.
तो तुम 200 ml
Skeletal or
Medullary? Medullary?
lymph nodes followed by distant metastasis to lung or liver.
liver met.
Liver met. Yeah. That is about metastasis symptoms. Okay. You go to next page, ma'am.
Madam, role of smoking and alcohol in thyroid cancer, ma'am.
Yeah. Does smoking have implication on thyroid cancers, Sahana? If so, which thyroid cancers are more, which variety are more common with smoking?
फैन अलाउड नहीं है
Poorly differentiated anaplastic.
Yeah, tell me.
Ma'am, they say the papillary thyroid cancer risks, there is a tendency of decreased risk for the papillary thyroid, but anaplastic and other cancer may rise with the smoking and alcohol.
Yes. ETC has it has reverse association with smoking, whereas the anaplastic dedifferentiated cancers have more association. Okay, fine. So, yeah, in general examinations, Anna, okay, what are the things you want to look at? Leave alone whatever is there, okay? So, per se, in a thyroid case, what do you want to look at?
Okay, whether the patient is conscious, oriented, anxious, is maintained, ECOG performance status, whether there is pallor, generalized lymphadenopathy, edema, living dead, eye signs for hyperthyroidism, signs of hypothyroidism like alopecia, loss of lateral eyelids, whether there is facial puffiness, then tremors, then with vitals, resting pulse rate, blood pressure recording.
Okay. So, if I have to ask you, so you told tremors, restlessness. So, have you heard of mixed edema phases?
Yes,
What is that?
It is in hypothyroidism. There'll be your puffy face, and if you in pretrivial region, it will be a non-pitting type of mixed edema. But faces will be like puff moon faces, like Kashik oil.
So pretibial mixed edema is it a misnomer or it is?
It's a misnomer.
So where is it seen?
Hyper.
Yeah. Okay. So there will be more of periorbital fluffiness. Okay. That blunt look. Okay. And mask-like faces will be seen in hypothyroidism. Okay. What about hair?
Thin loss of hair.
In brittle hair will be seen. Yeah. And what about skin?
It is cold, moist in hyper. It will be dry, flaky in hypo.
Toad-like skin it will be. Okay. So dry and stretched out like that. Okay. So a thyrotoxic. Is there any difference between thyrotoxicosis and hyperthyroidism, Sana?
The biochemical variation in the thyroid function test which represents is hyperthyroidism with clinical manifestation as thyrotoxicosis.
Yes, correct. What is primary hyperthyroidism and what is secondary hyperthyroidism?
The cause which is for primary hyperthyroidism, it is central cause with neurological symptoms are predominant, whereas secondary is
so why is it caused? Why is it caused?
Increase in thyroid stimulating hormones, which causes the thyroid to hypersecrete, whereas in secondary it is long-standing, becomes autonomous with more of cardiovascular symptoms.
Okay. Suppose it is due to the gland and it is due to the functional effect of the gland. So how do you classify which is functional effect of the gland and which is per se due to the hypersecretion from the proliferation of the gland itself?
Secondary is due to autonomous.
What is secondary?
Autonomicity of the gland, whereas hyperfunctioning due to secondary causes is primary.
So one is functional because of the oversecretion of the thyroid hormone from the gland itself. Okay. One is due to the proliferation of the gland. Okay. So secondary is more due to the secretions. Okay. Whatever secondary manifestations you get is due to hyper functioning gland. Okay.
Okay.
And whatever you get in primary is per se because of the overstimulation leading to the glandular changes. Okay. And okay, suppose if we talk about anything else which is important in the examination, you told pulse rate. What happens to the pulse rate?
In hyperthyroidism, the resting pulse rate is high. when the patient is calm and tested it over the right radial artery, there'll be more. So by Kreil's grading, it can be grade 1, 2, 3, 90 to 100, 100 to 110, and more than 110.
Okay. So suppose if you have, yeah. Suppose you want to see the pulse rate and BP. Okay, which BP will rise, Sahna? Systolic, diastolic, which will rise?
Diastolic will be more, I think, because of the recoiling.
Systolic in hyper, diastolic in hypo, I think.
Hypo is
So then
diastolic, ma'am.
YouTube चलता है क्या?
Yeah, diastolic.
So if you compare
मैं
pulse
अपना
rate
ISO के lecture
and
सुन
BP,
लूँगी।
okay, with the simultaneous rise of systolic and what do you say, the pulse rate increase. So what is your differential diagnosis?
If
And what do you say?
if there is tachycardia with increased BP, then it is
बिजनेस क्लास में
manifestation of
नहीं है हमारा।
hyperthyroidism.
Systolic BP
Brady
is
with
high, SBP is high, pulse pressure is high. SBP is high, pulse pressure is high.
hyper. Brady with the diastolic BP is more in hyper.
So SBP will be little high. There will not be much higher SBP with a large amount of pulse pressure difference in hypothyroidism. Whereas SBP will be very high with increased amount of pulse pressure variation in hyperthyroidism. Okay. So this is the difference between hyper and hypo with respect to SBP and pulse pressure. What if SBP rises, DBP rises, and pulse rate rises? What is your diagnosis?
Hyper. SBP, DBP.
No, it's not related to thyroid. It can be pheochromocyte. Okay. So remember these changes with SBP, DBP, and pulse pressure. Okay. So
Just tell it again.
if SBP is high, okay, pulse pressure variation is high, okay, it is hyperthyroidism. If SBP is high but not very high, okay, but large variation in pulse pressure is there, okay, that is hypothyroidism. Okay, pulse pressure is more variation, and if all the three are high, that is pheochromocyte. Okay. So do you look for tremors, and where do you look for tremors?
Over
मैंने
the
कंघा
tongue
यार
when it is
पापा आपको
kept
दिया था, वो
inside,
कंघा रखे कि नहीं?
and,
जगह बिना
and
कंघे के ही
when
पहुंच
it
गई
is
मैं। अमेरिका।
unintentional.
Sorry?
Tongue and hands.
अभी भी तो करना पड़ेगा
You
ना।
ask them to outstretch the hand with
So outstretched hands facing up or facing down? Palm facing up or palm facing down?
down.
Yeah, palm facing down with an outstretched hand. Okay, you'll put small paper.
Paper over.
So you might be asked how do you examine for
जाओ
tremors.
खाना पापा ले
Okay.
आओ।
And anything else which we look in a general
हो
examination?
गया, अब यहीं खा लो खाना। चल रहे। मेरे को अभी 1 घंटा लगेगा और।
ठीक है बैठो 9 बजे जल्दी खाने
BMI.
So you
खाना तो खाएंगे ना, सुबह से खाना ही नहीं खाया इन लोगों के
Okay.
चक्कर में।
Then faces, it is written there. Okay, we already discussed about faces. Anything
Fine examination.
पीने का पानी मिलेगा ना
Fine examination.
Here, okay, in this case, without like detail, we'll have to do with wrist.
Musculoskeletal examination has to be done because she is having right shoulder pain. Okay.
छोटी सी सिगरेट लेना
Then yeah, that's about general.
This one has any implication palm facing up or down? Like it has any implication or we
Generally, the tremors are examined. Tremors are examined. See, when your palm facing up, it is relaxed state. Okay. So if your palm is facing down and you put a paper, it's stretched out. When you stretch out hands, no, with that, you will be eliciting tremors more clearly. Okay.
Palm facing upwards is also for encephalopathy, ma'am. That flap.
well, that is
That
different.
is flap tremors is different. That is
Hyperextension, you see. Then there'll be flap.
that is different.
Liver failure, ma'am.
That is in liver.
Hyperextension at the wrist you have to do, and then it will flap.
Okay, fine. So in local examination, what do you want to look at?
We'll see at the here I put the picture. So location of the swelling,
देखो thyroid swelling
its extended surface. So this is a swelling with in extending from one sternocleidomastoid mastoid to other, which is about say 1 centimeter from the inferior border of the mandible, reaching up to the suprasternal notch with lobulated surface. There is dilated veins. Tracheal position cannot be made obviously because of the size of the swelling. Then
Anything?
there's no
Movement
visible
with
pulsation.
deglutition, did you said?
Movement with deglutition and protrusion of tongue. So with deglutition there is movement. With protrusion of tongue there is no movement. There's dilated veins, no scar, sinuses or visible pulsation over the swelling. Then no other
So
swelling.
Sahana, so you described location, okay? Site you described, size.
About say 10 cross 7 centimeter lat.
Give me more than that, I feel.
Yeah.
Okay. Shape.
This is bilobar environment, so it's like can we
It is
it's
irregular and extending on both right and left sides, corresponding to the areas of right and left lobe of thyroid along with the central quadrant. Okay, isthmus region.
Yeah.
Okay, can you see the lower border? Side, size, shape, surface, extent.
Yeah, lower body more obvious with deglutition probably, but yeah, you can.
Okay. Then, can you see anything else?
Got veins. Then we'll ask them to do Pemberton here.
What is Pemberton sign? Why is it why does it come?
The compression of the superior vena cava. We'll ask the patient to raise, keep it up, above shoulder over next to the ears for about a minute and see if there is plethora, cyanosis, dilatation of veins and shortness of breath.
Why does it occur?
Compression of the mediastinum, that is SVC. It can be primary here because of the muscular nodes.
Does it have any significance when you can see a lower border of the swelling?
If there are lymph nodes which is apart from the swelling, yes.
Retrosternal, when you can see the lower border, the question of retrosternal doesn't arise. Okay. So, anything else in inspection?
Here, because of the obvious size, this carotid pulsation here we can't really see no.
But you have to tell, okay, whether it is seen or not. Okay. Just go back to your inspection slide.
हमारा तो नहीं हुआ, हम 2 दिन से
Yeah. So what all you missed?
The size, extent I saw. Movement with deglutition I told it after you
ये विशाल आया होगा, कहाँ से आया विशाल?
Otherwise,
so you have to tell superior border. You told up to the mandible, just below the mandible.
उस साइड से आओगे तो लगेगा.
Right.
How can we say that they shifted to left side in this swelling? Inspection.
Which one?
because here you could not really see the trachea, no? Huh?
I think I have seen. Yeah, on palpation, I think I've just put it in inspection. Okay, it's on palpation. I'm sorry.
2-4 room देखे फिर ये देखे.
So what do you tell in palpation? You have already told this extent. Okay. So what is Kabat trachea, Sahana?
Long-standing thyroid causing pressure symptoms over the trachea, which cause weakness and the cartilage framework will not hold it, so it becomes weak. So it becomes collapsible after removal of the large thyroid. So that is Kabat trachea.
Okay. And what is Cocker's test, which I told here?
Cocker's test is to demonstrate compressibility, that is Kabard trachea, by this large thyroid. So, upon deglutition, if you slightly compress both the lobes simultaneously, there will be a stridor. So that is Cocker's test.
Okay. And ideal? What's importance of ideal? What do you want to look at? Tell.
The RLN function. So we want to see the cord, the position, the movements, and if you can see then the tracheal rings through that, if any it's collapsing or not, that infiltration or not, if you can see. Otherwise it's mainly for the cords.
Okay. Few more things. What is this Horner syndrome, Sana?
Horner syndrome is manifested as ptosis, meiosis, anastalmosis, and anhidrosis, secondary to cervical sympathetic chain involvement.
Okay. So it's triad of meiosis, ptosis, and partial ptosis. Okay. And loss of sweating, hemifacial sweating. Okay. So anything? Yeah. So retrosternal extension you told, right? So what are the causes of dyspnea in thyroid swellings?
One, it can be local compression, retrosternal extension, metastatic lung with pleural, then RLN involvement.
So it can be due to infiltration in anaplastic. It can be infiltration, local regional compression, and it can be due to cardiac failure due to secondary thyrotoxicosis, right?
Okay, yes.
That also can be there. Retrosternal, you told. Tracheomalacia, you told. Okay. Well, you told one for hoarseness of voices, infiltration of the nerve. Anything else?
In hypothyroidism, also thickening of the cords due to deposit, also they have changes.
Yeah, edema of the cord can itself cause. That's right. What are the other than this?
In
can diplopia be present in a vision? Can diplopia be present in eye signs?
With paralysis of the recti, probably yes. Or
not recti. What is the longest?
Sternocleidomastoid at the same side.
What is diplopia due to?
Rectus muscle, ma'am. Superior rectus muscle. Eye.
So generally, what is diplopia due to? Which cranial nerve? Abducens. Okay.
LR6.
Lateral rectus 6. Okay. So other than that, yeah. So whenever you are asked where from you will examine a thyroid swelling. So what is your answer on inspection?
Back.
In front is inspection. Palpation will go behind the patient.
So in front, even for eye sense, you stand in the back of the patient also. Okay. So right. Pizzillo you told, no?
Here we had to see even the consistency of the gland mobility.
Yeah, you didn't tell the consistency. Tell me consistency and surface.
Firm, irregular surface, firm consistency, bosselated surface, extent. Ma'am, here there is restricted mobility because of the size. If we want to check the infiltration of the straps, how do we do that?
It's beyond the level of the straps, no? In this swelling.
In any case, like if
you have to turn the patient to head to one side, opposite side. Okay, to put that ipsilateral straps into contraction. Okay. And okay. So what are the causes of scars, sinuses, and something you told, no? Like the skin changes over thyroid.
One, the stretch, long-standing compression of the SVC causing dilated veins over it. If it is infective or inflammatory etiology, like for long-standing, if it is lymph node, probably sinus, not thyroid swelling. And scars secondary to any previous interventions or FNACs.
Okay. Even in anaplastic, rapidly growing and causing rapidly growing swelling there and causing stretching. Okay, it might lead to skin necrosis. Okay.
Okay.
So yeah. So then I think we covered all the signs. No, any other signs if we have left? Okay.
Covered.
So now you tell me. Systemic examination. You will of course examine the musculoskeletal.
Here neck and upper limb for sensation, power, movements at the joints and power of the muscle, sensation over the medial, the palmar, the dorsal and the lateral aspect. Then neck, flexion, extension, shoulder, flexion, extension, abduction, adduction and elbow and wrist. So for all from C4 to T2.
Okay. So you tell me. So I'll this one. Where do you look for the pulsations? What is the site you will look for pulsations and why?
In the neck.
Neck only, ma. Where?
No. One over the superior pole of the thyroid, bruit will see.
Why superior pole?
The superior thyroid is more superficial, so you can get the bruit better there.
So what is the level at which you see?
At the superior part of the thyroid cartilage, at the Chesney's tubercle, or at the C6.
So you'll palpate against some bone. What is that?
Transverse process of the C6 vertebra.
Yes. So suppose based on surface, suppose it is smooth. What are your differential diagnosis in a thyroid swelling?
It can be simple cyst. It can be adenomas.
Can it be a colloid goiter?
Huh.
Can it be Graves' disease?
Firm, uniformly enlarged and smooth border, yes.
Yes, smooth.
Yeah.
Suppose it is bosulated.
Multinodular, long-standing multinodular goiter.
Okay. Suppose it is of soft consistency, colloid or Graves. Suppose it is firm.
Chronic thyroiditis, Riedel's thyroiditis.
That is hard.
Hard, okay.
Yeah, carcinomas. What is one carcinoma which might feel as firm or cystic?
Papillary.
Okay. And other than that, firm are multinodular goiters. Okay, solitary nodule and all those things. Okay. Hard will be generally carcinomas and Riedel's thyroiditis. Okay. Okay, fine. And anything? Yeah. I think more or less we covered all the sides. Okay.
And painful is dequire when painful.
What about percussion? Yeah, painful is dequerence. What about percussion?
Over the manubrium sternite for retrosternal extension or lymph node, mediastinal lymph node.
Okay. So whenever you describe thyroid swellings, after examination, you have to tell its origin. Okay, any features of thyrotoxicosis or mixed edema are there. Okay, whenever you're telling your diagnosis, you should always tell all these 4 points. That is hypo or hyperthyroidism. Okay, origin from thyroid. Okay, any signs of retrosternal extension, any signs of metastasis. So that's how, that is the diagnosis. Okay. You should tell age, you should tell the sex, you should tell about other comorbids as well as the hypo or euthyroid state. Okay. So that, and what is your provisional diagnosis based on that? Okay. Right. So all this have to be covered. Okay. So Stellvox is lid retraction. Okay. Staring look.
Okay.
Infrequent blinking with white palpebral fissures. Okay. What is Von Graves, Sana?
Lid lag.
Lid lag, yeah.
Lid lag. So Nabzijas, Geoffroy's, Mobius, Gelnex, yeah, that are about. What is malignant of the exophthalmos?
भैया ये दो रिमोट है क्या टीवी के?
The name says.
अच्छा एक ही रिमोट मिला।
So you tell me, in a case of malignancy, are majority of patients hypothyroid or hyperthyroid or euthyroid?
Mostly euthyroid to hypo.
Okay. What is the incidence of malignancy in hyperthyroidism? With hyperthyroidism?
It is less than 5%.
It is around 3%, less than 3%. Okay. So what is malignant of exophthalmos is due to infiltration of the extraocular muscles. Okay. All the recti and oblique muscles will be paralyzed. Okay. That is called malignant exophthalmos. Okay. What is phimosis?
Flush. Congenital flush.
It will be due to obstruction of venous and lymphatic drainage because of increased retroorbital pressure. Okay. Right. So other than that, in thyroid patients, the CNS reflexes may be like affected. Okay. Okay. Now coming to what do you want to do in this case?
So here,
take for example, for purpose of discussion, we'll not discuss it as metastatic. Okay.
Okay.
So same swelling, there is no bone involvement. Okay. Just tell me what do you want to do.
Okay. By ultrasound, I want to confirm it is thyroid swelling. Want to see suspicious area for biopsy and give a thyroid score for the same.
You want to do biopsy?
Sorry, FNEC. And nodal status.
When will you do biopsy in a thyroid swelling, Sana?
In anaplastic and lymphomas, suspected lymphomas.
And metastasis. Okay.
Metastasis, okay.
So, otherwise FNAC will suffice. So, what do you know about FNAC in thyroid swellings?
In thyroid, we do non-aspiration cytology, where pre-vacuumated syringes given multiple passes. We take about, we prepare the slides where there'll be 5 to 6 groups of groups with 10 to 15 cells for adequate cytology. And mostly it is a non-aspiration because it's very vascular and here it is long-standing also. There'll be increased chances of bleeding and bloody aspirate.
Okay. Any grading for FNAC? You told which gauze? Which gauze you will use?
This is 22 to 23.
Yeah, 22 to 25. 22, 23 and 25. Yeah. Why?
Small. It should not be traumatic, bleeding, and it will cause...
thyroid is very vascular. So, use it as thinner as possible. And how many groups of cells?
5 to 6 groups, 10 to 15 cells per group.
Yeah, 6 groups with 10 to 15 cells each. Okay. Yeah. What is the advantage of FNAC?
One, we will know the cytology.
Okay.
And based on that, we can base our treatment.
Okay. Fine. So now you tell me what is the what is the classification for FNAC?
Bethesda cytopathology reporting.
Yes. Tell me that.
So there are 6 categories, starting from 1 to 6. Non-diagnostic. That one is non-diagnostic. 2 is benign. 3 is uncertain significance. 4 is follicular neoplasm. 5 is suspicious of malignancy. 6 is highly suspicious of malignancy. And there is risk of malignancy associated, like by percentage. If it is not diagnostic, it is little higher. I think 5 to 15. 0 to 3 is normal. With if it is unknown significance, it is 10 to 15%, 30%.
You are telling
Bethesda.
You are telling post CBIS paper, no? So,
then 30%.
So non-diagnostic or unsatisfactory smear will have how much risk of malignancy and what you are supposed to do?
Here it is higher than the 2, that is normal. So it is about 5 to 15%. So we'll have to repeat under guidance. First, if we have done ultrasound, again we'll have to repeat under guidance.
Okay. So you are getting little confused with Thyroids and you are getting confused with Bethesda. So that happens for everyone. Okay. So the only solution to that is just before your exam you see. Okay. So it happens to everyone because they are so vague numbers. So just remember to, in a easy way I'll tell you. Okay. Suppose it is non-diagnostic or unsatisfactory. It is more risk of chances of malignancy than a benign, right?
Correct.
So remember it is 1 to 4%. Okay. So benign will have 0 to 3%. Okay.
Okay.
Right. Now everything will be in multiple before CBIS paper. These are easy to remember, and it will give you little close values to post CBIS papers. Okay.
Okay.
So first will be 3. Okay. First non-diagnostic you just remember 1 to 4.
1 to
then
4.
will be 3. Yeah. Then will be 3. Then 5 times 3. Okay. 3. 15. Okay. 5 to 15. ATP of undetermined significance and follicular lesion of undetermined significance will be 5 to 50. Okay. Then will be follicular neoplasm, right? So suspicious of follicular neoplasm or follicular neoplasm, that will double. Okay, 30. So 3, 15, 30.
30.
Okay. Right? Then it will be next will be again double 30 to 60, right? 60 to 75. Okay. That is suspicious for malignancy. Then malignant will be 97 to 99%. Okay. This is little easy to remember. Okay. Suppose it is non-diagnostic, what you want to do?
Repeat the FNAC.
Okay. So you want to do it under ultrasound guidance or blind?
Ultrasound.
Okay, we'll discuss about ultrasound. Okay, we'll come to ultrasound. Okay. What about benign nodules? What do you want to do?
We will see the size. If it is, since it is the thyroids, we'll see. If it is cystic, spongiform, in all of them, less than 1 centimeter, you need not do anything. More than 1 centimeter with any suspicious features, like if it is not
so if as per ATA guidelines, how much nodule with high suspicion should be investigated, evaluated?
Okay, depending on the thyroids, the mild, moderate, and the highly suspicious, there is cutoff for size. 2.5, 1.5, and 1 centimeter.
1 for high.
High intermediate.
Generally, to remember, it is more than 1 for high and more than 1.5 for low, and very low, more than 2 centimeters. Yeah, more than 2 centimeters. So, or any with high risk features, even if it is less than 1 centimeters, you need to investigate.
Yes.
Okay. Then, yeah. So, what about do you know? I was telling CBIS paper, no? So, what is that?
There are 2 risk of malignancy, but I don't know the details of it. They've
yeah. So generally, this they have class. What is TBS? One is Bethesda. You told, no?
एक मेरे को भी दो पूरी के सर.
One is British system.
British.
Okay. So British and Thai are there. Okay.
Yeah.
So these also are similar values. Okay. 1 to 4 was there, no? TBS 1 has 1 to 4. Okay. Risk of malignancy. And TBS 2 has less than 5%. There it was 3, na? So there will be less than 5%, and more of them will be false negative. Okay, in this group. Okay.
British.
Then yeah, and TBS 3 will have there. How much it was?
3 is 15 to
Correct. 15. Na? So here it is 6 to 48%. Okay. 15 to 30. Na? So nearing is some 30 and 40 like that. Okay. And but the variation will come in TBS 4. Okay. It will be less than TBS 3. Okay.
Okay.
It is 14 to 34%. Okay.
Okay.
And 5 will be 5 for 5. So 50 to 80%. Okay.
Okay.
And TBS 6 will be malignant. Okay. So that is about, yeah. Now you tell me, FNAC will detect what features on FNAC you'll see in papillary thyroid cancer.
So the nuclear features and some of bodies, the nuclear features will be enlarged nucleus with lobulated appearance, with large nucleoli ratio, convoluted, long oblong nucleus, orphan annii appearance.
So first thing you will see is a cellular smear in papillary. It will have more cells. Okay. That cells will be atypical. Okay, atypia will be seen. Okay, first cell, then atypia. Then go to nucleus. Nucleus will be enlarged. Nucleomegaly will be there. Okay. Then there will be overlapping. Okay. Then you will see powdery chromatin if you come inside nucleus. Okay, powdery chromatin. The cellular membrane will be irregular. Okay. And intranuclear inclusion grooves will be there in papillary. Apart from that, inclusion bodies and orphan annii appearance of them. Okay. So these are seen. These are the features of papillary. What about follicular?
Follicular, the histomorphology will be the follicular architecture. There won't be this papillary, this one. There'll be follicles and nuclear atypia will be there with loss of.
So tell me, can FNAC tell that whether it is follicular carcinoma or follicular?
No. The invasion by capsular vascular cannot be made out. That is post-surgical specimens.
So previously, like Hertel cells they used to see. Now it is separate, no? So that
oncocyte.
Okay. Yeah, and in addition to that, you can do FNAC from the nodes also in papillary. And what will you see in medullary?
In medullary, it is round cells, like uniform round hyperchromatic cells with
वेस्ट है आपका खाना.
Where will you see amyloid body?
Amyloid rich stroma.
Amyloid stroma. Then in anaplastic, what do you see?
A spindle and varied type of mixed architecture. There will be bizarre cells, increased cellularity with stromal infiltration. There will be the stromal and the cellular ratio. It will be dense and different architecture of the cells. Spindle to various different types.
Okay, spindle cells. Do you know the types of anaplastics here, Sana?
जब तुम लोग
one you told spindle cell.
Spindle, epithelioid, and
Epithelioid.
spindle.
Okay.
Formation of them.
There are 5 types. You will tell homework. Okay.
Yeah.
Okay. Oh, by the way, what is Bethesda? Sana?
It's the place.
Yeah, the place. Okay. Fine. Now you tell me about something about ultrasound.
Okay. High frequency ultrasound about 10 to 12 megahertz. Then we will see for the nodules. Then we characterize them by 5 features. We see the composition, the echogenicity, the vascularity, the echogenic foci, and their size, whether they are taller than wider. Then we have given scores to them. If they are purely cystic or spongiform, they have mixed cystic solid, and their margin irregularity, their vascularity, and their echogenicity. So there is Thyroid scoring 1 to 5.
So if you are asked about 5, tell me 5 features of in any report which you will look for.
Microcalcification.
Yeah,
Okay.
you tell me from starting.
Okay. I will see for taller than wider, with echogenic foci, where its echogenicity, with its hypo or iso with the thyroid parenchyma.
So which are iso?
Hypo is more malignant than iso.
Suppose I say iso can also be malignant.
Yes, then I'll look for other features associated.
No, which malignancy would it be? More of iso and hyperechoic.
Follicular.
Yeah. So papillary are more hypoechoic.
Then I'll see for irregular margins.
Okay, microlobulation
and echogenicity, that is solid component with it.
And taller than wider.
Taller than wider.
Why taller than wider? Any reason?
That is that the elastic difference between a growing nodule and normal parenchyma, and because when we compress through the ultrasound, that is how it appears.
Yeah, compressibility, it all depends. Tell me thyroids.
Thyroid.
So there are many thyroids. Okay, what we follow is.
Ma'am, there was one question that was asked in a class. One malignancy that does not have this taller than wider characteristics.
Which will be? You tell me. Which is not compressible at all in among the malignancies?
Anaplastic.
That's the answer. Okay. Yeah. Tell.
So it is 1 to 5. One is normal, benign, and 3, 4, 5 is the risk of the suspicious, whether it is low, intermediate, or high risk of suspicion.
See, 1 is negative. Okay. 2 is benign. 3 is probably benign, means no ultrasound features, or less than 5% chances of malignancy is there. Okay. The chances of malignancy starts from 3. Okay.
3, yeah.
It is 0 in 1 and 2. Okay. 4 is suspicious of malignancy, wherein incidence of malignancy is 5 to 10%. Okay. Again, 4 is divided into 4A, 4B, and 4C. Okay. If one suspicious features among what we discussed, what are the 5 suspicious features we discussed? Solid, hypoechoic, irregular margin, calcification, and taller than wider. So amongst these 5, if there is only one suspicious features, then it is 4A. Okay. And if it is 2 suspicious features, it is 4B. Okay. If it is 3 to 4 suspicious features, it is 4C. Okay. So incidence of malignancy in 4, okay, it is 4A is 5 to 10%, whereas 4B is 10 to 15%. Okay. Whereas 4C it is 50 to 85%. Okay.
Okay.
And 5, it is highly suspicious of malignancy, where then more than 85% chance of malignancy will be there. Okay.
Okay.
Thyroids is easy to remember. 5, 5 to 10, less than 5, 5 to 10, 10 to 50, 50 to 85, more than 85. Okay. And 6 is biopsy proven. Okay. So how many ultrasound alters treatment in how many percentage of people?
25.
Alter surgical approach, 20%. Okay. What probe you told?
High frequency 10 to 12
Yeah, 10 to 15 around. Okay. So yeah, that is about thyroid. Okay. So and what else? Yeah. Then can you tell me Suppose in this, tell me something about rule in and rule out.
Okay. My RNA
उसके बाद
based
जॉब भी रहती है इन
studies,
लोगों के पास
there's
रिटायरमेंट होने के बाद
174 RNAs used in two commercially available testing kits by NGS or NGS, and on the biopsy specimen they run these NGS tests. So
No,
to know the
Sana. What is
sensitivity
rule in? What is rule out?
in BIRATS 3 and 4, if you want to for there are sensitivity and specific, some tests are sensitive and some are specific, whether to rule in whether the risk of malignancy is high. So that is rule in, where the sensitivity of the test in knowing the risk of malignancy is more. Rule out is they are more specific. If they are positive or negative, you can rule out the risk of malignancy. So
you told wrong.
RNA based.
Anything,
Spin.
anyone can correct her?
Spin. Okay.
So there is a trick, ma'am. Spin and snout. Spin SP positive is rule in. Highly specific positive is rule in. And snout highly sensitive negative is rule out.
Yes, correct. Okay. Yeah. Yeah.
Third and fourth,
जाएंगे कोर्स कंप्लीट होगा फिर जाएंगे
third and fourth.
So what are indeterminate Bethesda?
Yeah.
Indeterminate category.
In 3 and 4, to rule that they are benign, we do rule out test in them. In 5 category, it is more of a malignant. So we will apply rule in test the 5, so that to categorize more into the malignant. So in 3, 4, rule out tests are to be applied. In 5 category,
पापा
rule
ये
in
पहन के
tests
एयरपोर्ट
are
नहीं
to
ले
be
जाना है आपको
So what are the rule in test? You know.
Madam, those
Sorry.
7G.
Affirma is ruled out and
दीन दुखी आ गए उसके
Okay, let
पापा
us
आएंगे
discuss
तब
about
से
molecular.
बैंगलोर
I'm
से आ रही
just
हूँ
molecular markers. Okay, we'll discuss about that. What is rule in test? It is 7 gene panel.
7G.
What is rule out? Gene expression classifier. Okay. So what are the 7 genes that you are looking in 7 gene panel?
RAS, BRAF, TERT, P53.
4 mRNA, 3 ऐसा कुछ।
स्पॉन्सर कर देते
Sorry?
4
Tell me all
लगा
7.
के सब जा
Anyone tell all the 7 genes which we are
BRAF,
looking?
NRAS, BRAS, NRAS, HRAS, KRAS, rate PTC C1, rate PTC C3, PAX8 and
ब्राव
PPARA alpha.
Yeah, PPR
गामा
A alpha.
or gamma.
Gamma, sorry, gamma.
Right. So, what is, by the way, I forgot to ask that question. What is NIFT, Sahna?
Non-invasive follicular variant with papillary features. It's a
What is exactly this?
it's a low risk potential type of variety which is well encapsulated. It has got papillary features. The nuclear features are like papillary. They have very low risk of malignant potential.
So they are benign most often. They have a fibrous capsule. They are encapsulated. And there will be no extrathyroidal extension, no infiltration, no capsular invasion. Okay.
यार ऐसी तो
So
नहीं हूँ मैं
this should be satisfying all the whatever criteria are there to be called as NIFTIP. Post NIFTIP again they have given a classification. Okay. So yeah, fine. Then what was I asking? Yeah. So suppose by seeing all these tests, whatever Bethesda, Thyroid, how many unnecessary surgeries you can avoid if you can stick to all these things?
ये जंग भी हम जीत लेंगे अब सोच लो अगर मैं अमेरिका से अच्छी सही सलामत वापस आ गई
30%.
सुनो मेरी बात
you can in cases of benign swellings, you can avoid around 70 to 80% of unnecessary surgeries. Okay. If you don't do surgery in those which are suspicious, around 10 to 15 will progress in them. Okay. Clear? Yeah. So now you tell me molecular marker testings. What test do you know?
You need a companion.
Anything available in India?
एक नहीं तुम्हें दिन दिन तक का कंपेनियन
Yes, anyone?
Commercially available kits.
How much does it cost? How much does it cost?
2 lakhs, ma'am. 1 point.
पापा का नया
Around 2
लड़का
lakhs.
ढूंढ रहा था, उसका देखा था।
1 to 2 lakhs.
यहाँ बात चला रहा, मेरे मैसेज
Sure.
पे बोला I am
I think it's
officially
more than
engaged
that.
right now.
So, okay, fine. What is Afama? Is it rule in or rule out? Rule out.
पिताजी को
Rule
ऐसे
out.
तो लड़के मिलते हैं।
Okay. And what is it done on?
तो biopsy just shows
Biopsy tissue.
FNA process.
Which is it a tissue or FNAC? Sorry, I'm not able to hear everyone.
Tissue, madam.
See, only one is done on that smear. Okay, that is Rosetta. Okay, rest all are through FNAC only. Okay, right? Okay, then what is tested in Afama? It's mRNA. Okay, and Thyroid and all they'll be done through NGS PCR and all. Rosetta, it is microRNA. And what is Thyroid? It is in or out? In and out both. Combined. Both. What is in? Afirma is out. Then what is in? Thyrogenics.
Thyrosec is in, madam.
ब्राह्मण तो वाकई
7G.
पापा पसंद नहीं आ रहा है।
Rest both are both in and out. Okay.
Thyrogenics.
Okay.
क्यों? तीनों लड़के
Then like what can detect more of the results of Afama will be stated as either benign or suspicious. Okay, Thyroid will tell what translocation and genetic mutation it has. Okay, and more of benign nodules will be well characterized by Rosetta. Okay? Then how many cells should be there when you prepare direct smear in this molecular?
एक बार में पापा को ढूंढ लिया आपके लिए नाना जी ने, और पापा देखो
It should be around 60 cells at least in that thin prep smear. Okay. What are advantages of this? You told one is to characterize the indeterminate nodules, right? Suppose they are very rich, they can get it done. Suppose they are poor, what you will do?
Then surgical biopsy. You will have to go for one. You can in Bethesda 3 and 4, the option of lobectomy as a surgical biopsy.
Okay. What are limitations of this molecular test?
देखा कितना अभी नाना जी की बात हो रही थी।
Limitations. It is costly. Okay.
Availability.
Whether cost.
Yeah, they are not available.
And they're not 100% confirmatory to rely on your decision.
Yeah, they're not for all histologies. Okay. So they do not conclude all the histologies. Okay, they might tell it is malignant and all, but specific to all histologies like medullary and all those things cannot be excluded. Okay, and it is costly. Okay, it is not foolproof. Okay, and there is no equivalence. Okay, and it is complex, cumbersome method. Okay, then yeah. Next, any other
10 बजे निकल जाएंगे।
imaging modality, you know?
No, for this we'll have to do CCT neck with thorax.
आप बात करो।
Okay. What are the what do you want to look at in CT? In a thyroid swelling?
मेरी नहीं जा रही।
No, here you forget it. just we are discussing thyroid swelling.
Hello, Papa.
Okay, suppose only swelling, no metastasis. What do you want to do?
Okay, we'll have to
CT
look at
characterizes what better?
the nodal status and the relationship of the swelling with the surroundings, so that you can have a surgical plan.
So it will characterize locally advanced disease better, with any infiltration to laryngeotracheal framework will be better characterized. Yes. Okay. So do you want to do CCT?
Now they say that iodinated contrast does not interfere in your radioiodine if needed in your adjuvant therapy. So we still
It
can
washes out, so it is not so risky, they say. Okay, but still some people do not do a CT. Okay. What about MRI?
here MRI, because we'll have to see for the cervical and the thoracic spine and compression and for neurological intervention if needed.
I'd say in a thyroid swelling, when do you do MRI?
Vascular invasion.
Yeah, vascular invasion. Esophageal.
Esophageal.
CT is for laryngeotracheal framework. MRI is for vascular and esophagus. PET.
Upfront, there is no role of thyroid.
What are the indications of PET in a thyroid swelling?
If it is a dedifferentiated or a medullary thyroid cancer.
Too early differentiate anaplastic.
Radioiodine refractory, ma'am.
Okay.
Radioiodine
So
refractory.
all of you are correct. Anything else when you want to do PET? When nodal burden is more, when the incidence of metastasis is suspected.
Clinical suspicious of mate.
Yeah. So what is incidence of
medullary
suppose
thyroid cancer, ma'am? For syndrome assessment, we should go for CCT.
One of the indications for PET is medullary thyroid cancer. Dedifferentiated thyroid cancers, including medullary thyroid cancer, okay, with any suspicion of mets, and where you are suspecting that they have dedifferentiated with absent radioactive iodine activity, you will do a PET with increased nodal burden and suspicion of metastasis. Suppose, Sana, you have seen some FDG avid nodule on PET. What are the incidence of malignancy in a PET avid nodules?
30%. So they
What
have
are
a
those
high
called?
pickup. 30.
Incidentaloma.
Anything specific in thyroid? You call them pains. Okay, PET associated incidentalomas. Okay, right. So that is about more or less what all the imaging is. Now coming back to the biochemical. Okay, tell me what all you want to see in biochemical.
Thyroid function test, TSH, T3, T4. And
so what is the first investigation that you want to do in a thyroid swelling?
The TSH, the thyroid function test, where we see the TSH to know whether it is hyperthyroidism or not, because RAS cancer indicated in hyperfunctioning gland. Then plan for an FAC.
So what is T3, T4, TSH?
The range,
not the values.
Range. 0.3 to 3.3 milli international unit per ml is TSH. T3 is 3.5 to 7.5 nanomole per milliliter. T4 is 20 to 80
picograms.
Yeah, picogram.
Fine. It varies from lab to lab, but roughly you should know. Okay. So generally TSH, you remember 0.5 to 5. Okay. So then suppose TSH is low. What do you want to do?
Hyperthyroid.
Then it is hyperfunctioning gland, radioiodine cancer indicated.
Okay, radioisotopes cancer indicated. So what can it be? What can be the differential diagnosis in a low TSH thyroid gland?
It can be Graves' disease, It can be hyperfunctioning warm nodule. In the milieu of increased functioning gland, if there is a cold nodule, then there is increased risk of malignancy, about 5 to 15%.
How many cold nodules are malignant?
By percentage, it is 15 to 20% of them.
Yeah. And what about if TSH is high?
It is hypo, then you will have to investigate for features of Hashimoto's thyroiditis, then suspicious nodal FNAC.
Can it be goiter or lymphoma?
Possible.
Yeah, it can be. What happens to TSH in malignancy?
It can be normal or high.
How high?
Not upper limit of normal.
It's upper limit of normal. Okay. Yeah. Anything else you want to do apart from TFT?
This calcium and others. This one, is it like, should we tell when we are suspecting a differentiated thyroid?
Yeah, you can do calcium. Anything else?
LC tonic.
Thyroglobulin.
Thyroglobulin. Antithyroid.
What is important? I am hearing my own voice here.
Yeah.
Somebody quick. So what is do you do thyroglobulin preoperatively?
No, ATA guidelines say there is no role for preoperative TGs, but in like metastatic setting and all, they usually do an
There is role. There is role. Higher the values, it tells the differentiation of the tumor.
So for all practical purposes, there is no role of thyroglobulin pre-op. Okay, remember. And except
Baseline marker can be baseline value.
Yeah, if you want to compare it. Okay. And anything else?
normal pre-op workup, your hemoglobin and all that.
No, not that.
Third antiglobulin body. Thyroglobulin antibodies now.
Yeah, antibodies. I was looking for that. Hey, I'm hearing my own voice here. Somebody mute. Okay. Did you people mute?
But in the pre-op setting, when we are doing it, is majorly thyroid function. What?
One second, yeah.
बात कुछ नहीं बच्चे हैं अरे इधर करो मेरे को यही बस आपकी नहीं पसंद क्या नहीं पसंद ये इतना नहीं बच्चे जितने बच्चे हैं उतने बच्चे हैं जो फोन आया भाई मासी उनको भी चैन नहीं होता अरे दी चालू कर यार लो
and RCTs. So, in terms of oncological safety complications, and with the size criteria for less than 1 centimeter, Hemi is approved. 1 to 4, there are different schools of thought. So, total is better than Hemi was given by Billy Moria et al. Where they said that for 1 to 4 centimeter intrathyroidal swelling with N0 and M0, doing total thyroidectomy over Hemi gives a survival advantage. Whereas other studies by Hay et al., by Zhang and Nixon et al., they said Hemi is comparable to total thyroidectomy in terms of recurrence and overall survival, and we have a lesser complication rates.
Yes. Yeah. So other studies are apart from what you named are Adam et al., Mendelssohn et al. So all this. So what is the if it is less than 1 centimeter and if it is papillary? So what do you call it?
Microcarcinomas, papillary micro-PTCs.
Madam, I have confusion. There is overall sort of survival advantage. In Vilmoria, with total thyroidectomy, there is overall survival advantage.
Yes. No. What they have told is Bilmoria et al. When they have compared, that's the only study we told. Hemithyroidectomy is better than total thyroidectomy. In terms of
Local
Survival recurrence with survival, I think. I'm not sure about survival, but contralateral recurrence rate was more with.
What happened is they had less incidence of complications. Okay, so there was more morbidity and mortality in those who were in whom total thyroidectomy was done compared to hemithyroidectomy. That was fallacy with that study. Okay,
overall,
but
was same.
It was same. They told trend to overall survival was there, but not proved overall survival. Okay. Yeah. So as there are no randomized control trials in it. Okay. So and yeah. What about microcarcinomas? What do you want to do?
In microcarcinomas, we'll have to see for the location the symptoms. There are two options that you can give. Active surveillance is one. If they are ideal candidate with strict criteria by the nodule and disease, by the disease factor and the host factor, then there is role for surgery as hemithyroidectomy.
Sorry, your voice got cut.
You can do active surveillance or you can offer hemithyroidectomy.
Okay.
For active surveillance, the patient should be an ideal candidate by host and disease factors.
Okay. So, what about now? In relation, can you tell me what is low risk, what is intermediate risk, and what is high risk?
Okay.
As per ATM.
Surgical histopathology.
Histopathology.
So we dynamically risk stratify them. We'll see for TNM status, that is N0, non-metastatic, intrathyroidal, non-aggressive variety, micrometastatic less than 5 lymph nodes are low risk category. Nodes are positive, but they are more than 5 in number. They are aggressive type. Then minimal extrathyroidal extension is intermediate. Metastatic gross residual disease, extensive angioinvasion, more than 3 centimeter nodal burden, they are high risk.
Okay. To simplify what you told, like if they are intrathyroidal with less than 5 lymph nodes and less than 0.2 mm micrometastasis in each node. Okay. With this one, these are low risk. Okay. And what are intermediate risk? They might have aggressive histology, but minor extrathyroidal extension. Okay. Vascular invasion is there. Okay, but more than 5 lymph nodes are there, but each lymph node has 0.2 to 3 centimeters. Okay, and more than 3 is high risk, and they will have incidence of extrathyroidal extension or gross extrathyroidal extension with incomplete tumor
resections.
And they will be like intermediate risk, may or may not respond to radioactive iodine. And low risk?
There is no role for radioactive iodine.
Yeah, you can just observe. Yeah. And high risk?
High risk, it is considered. It should be given. Intermediate, you can consider radioactive iodine.
Okay. One more thing I forgot in imaging, which will pick up peripheral lymph nodes more and which will pick up central lymph nodes more?
CT has more pickup for central ultrasound and CT are comparable for lateral, but ultrasound is superior.
Ultrasound is superior for peripheral.
Yeah.
So, what is your thought about painting with betadine?
They say for in radioactive requirement, if that is left for a long time and there is imbibition, then might interfere. Otherwise, not very substantial. But chronic usage of superficial ointments and syrups.
So whenever you paint, don't irrigate with betadine. That is the main thing. Okay. So as long as surface painting will not matter.
Yeah, it should not get into crevices and stay in there.
Yeah. So
The ointment to use should be prohibited. For wound care.
Yes. Post surgical, post incision, don't try to use betadine. Okay. So yeah. So how much margin you want to give, Sana?
So 1 minute. No, you'll have to take it into 1 minute.
So is it different for differentiated thyroid cancers and undifferentiated?